Today, we're taking a critical review of Andrew Huberman's podcast on low back pain. Is it scientific? Is it genuinely evidence-based? Or is he just pulling stuff out of his butt and making things up? I'm going to watch it so you don't have to.
A few moments later.
He has not cited a single piece of peer-reviewed research, and he's a frickin' PhD. Dude, come on. Hold yourself to a higher standard than that. Now, real quick, I'm Dr. Anthony Davis. I specialize in chronic back pain and sciatica. That is all I do. But this is not about credentials. This is about the research. And one of the frustrations I've seen in these types of popular figures is that they say a study found X or Y, but they don't really reference the study, or you dig into it and the study that they quoted doesn't actually say what they said it says. So we are going to review the actual research and fact check the hell out of Andrew Huberman, because spoiler alert, some of the things he's saying are fantastic, but a lot of it is bullshit that is going to keep you stuck in pain and spinning your wheels in this purgatory of just endlessly chasing alignment and core stability and things that do not matter. They are a waste of time. So let's separate fact from fiction today.
Huberman, and I'm a professor of neurobiology and ophthalmology at Stanford School of Medicine.
So right off the bat, he's neurobiology and ophthalmology. He is not a practicing licensed clinician to treat and manage back pain and sciatica. In other words, this is not his field of expertise. Although I am interested to see what he has to say about the neurology.
One of the things about pain, in particular back and neck pain, is that it also has an effect on our emotional self. It makes us more irritable. It makes any activity, even the most mundane activities, that much more distressing to carry out.
This is great. Right away, he's hinting on the fact that back pain is not just about your anatomy. It also affects your mental health, your mood, fear, anxiety, depression, irritability, all kinds of things. So cool, we're off to a good start.
And importantly, the biopsychosocial model of pain, whereby our thoughts and our perceptions about pain actually influence the severity and the duration of that pain.
Fantastic. Great start. Biopsychosocial model of healthcare. We need to look at the body, the mind, the environment in order to understand why somebody is in pain. Because pain does not boil down to just, oh, this little muscle, or just the disc herniation, or your joints are out of alignment, or this muscle is tight. It's bigger than that. Chronic pain is multifactorial. So great start.
Just for generating a really strong, stable core, strong spinal erectors, making sure that your pelvis and your spine are interacting correctly, that your shoulders, neck, and spine and pelvis, and even your lower limbs and feet are working together in the proper manner.
He was off to such a good start. And then he had to throw in a bunch of unscientific dogma about alignment and core stability that has been thoroughly debunked. I will show you the studies, but I'm going to wait for him to actually make a specific claim so that I can specifically debunk it. But I have a feeling he's going down a rabbit hole of very non-scientific, opinion-based stuff. We'll find out.
But keep in mind that the vertebrae and the discs have a hole down the middle. They look like donuts, basically. They're not perfectly round like donuts.
I'm sorry, did he just say the discs have a hole in the middle? Here, there's no hole where the disc is. This is a disc. There's no hole through the disc. Not a good start.
The time being, just think of them as donuts, right? Some are bony donuts and others have more pliability to them.
No, don't think about them like donuts. They're not like donuts. They're so tough. They're like dense rubber. They're cartilage. If you think of it like a donut, then you're going to think that your spine is fragile. So I hate the donut analogy.
But there's a hole down their middle. Why? Well, within that hole,
you know, I'm starting to think maybe it was not a mistake, because he continues to make the same mistake over and over, describing it as though the spinal cord is going through and that discs are wrapping around the spinal cord, which is very, very clearly not true. And he said it 3 times now.
And that's really important because the spinal cord, this long tube of neural tissue that sits inside of the vertebrae and the discs.
4 times now.
And then extending out from the brainstem, you have the spinal cord, this tube-like neural structure that extends down through the vertebrae, down through the discs.
5 times. Look, if you're going to give a long-winded explanation of the anatomy, at least get the basic anatomy right.
And oftentimes the source of back pain or neck pain or even pain in the pelvic region is because of a compression of the nerve roots that are going into and out of the spine.
Couple quick things. First of all, yeah, obviously if a nerve is severely compressed, that can definitely cause pain. It's important to know that the size of the nerve root is very small compared to the holes that they travel through in these foramen. So the nerve root actually has tons of room to move around in the foramen as they exit from the spine. So even if there was a little bit of bulging that was pressing on a nerve, the nerve doesn't just get squished. The nerve just kind of moves a little out of the way in most cases. L5 nerve root is between 2.3 and 7.7 millimeters. So let's just call it 4 to 5 millimeters. And then this study was looking at, okay, so if we have a 4 to 5 millimeter nerve root and it goes through a hole, how big is that hole? Is it also only 4 millimeters around? No, it's much bigger. So here we found that the height, the average height here was around 19 millimeters. Width was ranging between 6.4 and 12 millimeters. So we have plenty of extra room. So even if the nerve is a little bit pressed on by a disc herniation, it doesn't necessarily mean that it's going to be actually squished. It might just move a little off to the side and not be a big deal.
What we're really trying to do when we talk about relieving back pain often is creating space, creating room for those nerve roots to travel in and out of the spine.
Again, yes, of course, if the nerve is severely compressed, you can have nerve pain. But that would be a true radiculopathy. That would be specific pain. Most pain is non-specific, meaning we do not have an identifiable single structural cause of the pain. So he has spent nearly 20 minutes describing anatomy, and it doesn't matter in most cases because, again, most back pain and sciatica is non-specific, which means there is no such thing as a single structure in the body, not a joint, not a ligament, not a muscle, not a piece of cartilage, a disc, nothing, not a nerve. We cannot point to a single structure in the body that is responsible for your pain. And he has spent a lot of time describing the anatomy so that he can make the point that nerve compression is a very common cause of back pain and sciatica. And surprisingly, I know it sounds reasonable, but again, here's the literature. Most back pain is non-specific, meaning it's not caused by nerve compression. Not to mention, here's another one, and I could cite literally dozens of these studies that look at spines and find that most people are walking around with pretty bad disc herniations, disc bulges, disc protrusions, sequestrations, extrusions, in other words, disc swelling, and yet they have zero pain. So you actually do not need, for most people, you do not need to change the amount of compression on the nerve because your pain is not caused by compression of the nerve in the first place, even if you have a disc herniation, because most people have a herniation with zero pain.
Not all of back pain is neural in nature. Now, technically, all pain is neural in the sense that it's a perception.
I like what he's saying here, although he's kind of contradicting himself. If you understand that pain is neural in the sense that your brain is interpreting all of the signals between memory, context, expectations, beliefs, sensory inputs, etc., filtering it through its own lens, and then deciding essentially whether or not to activate the pain alarm system, if you really understand that, why did you just spend 20 minutes of your podcast talking about bony anatomy and nerve compression when that is just a very, very tiny, tiny piece of a very big pie? For the record, these are the actual things that cause back pain and sciatica, really any kind of chronic pain. So here we have pain in the center and its influence. All of these things are interrelated. So down here, sure, we have things like tissue damage, degenerative disc disease, nerve compression, etc. Those are definitely part of the picture. I'm not discounting that, right? But then we have neural changes. These are changes in inflammation, changes in neural signaling, basically what we would call neuroplasticity or systemic inflammation. Central sensitization basically means that your nerves are more likely to send off what we're going to call a danger signal, a nociceptive signal, to your brain versus a normal desensitized nerve. So we've got things like chronic inflammation, chemical sensitization, neurotransmitters that change, and that's not damage, by the way, right? Neurotransmitter activity leading to more of a heightened alarm system and therefore more pain does not mean that you're in damage. So it's really important to understand that even the physical factors that lead to pain are not all because of damage. Your threshold for pain is so low that when you have pain, it is not necessarily an indication that you're causing harm. You might just be too sensitive because everything is inflamed. But then up here, we've got things like unpleasant sensory and emotional experiences, a positive outlook, perceived threat, fear of pain, pain catastrophizing, resilience, coping style, avoidance, and safety-seeking behavior. And I could go on, right? Here we have some other identity, BMI, flexibility, genetics, physiological risks. And then it gets interesting over here. We've got beliefs and culture, autonomy, even spirituality has an effect on your pain, your work status, your social engagement, low income, what do you do for work, socioeconomic status. So are you getting the picture? This one's really interesting right here. It says health provider beliefs. So if your healthcare provider has outdated beliefs, like that all of your back pain is caused by nerve compression and that your discs have a spinal cord that goes through them and doesn't even understand basic anatomy, then that's going to rub off on you. If your healthcare provider is afraid of spinal pain and afraid of bending and twisting and lifting and all those kinds of things, and they tell you, oh, just take it easy, don't push it, and oh, you got to brace your core all the time, those beliefs are going to lead to bad outcomes for you. And then, of course, we have other factors like poor sleep, poor diet, smoking, drug use, alcohol abuse, that type of thing. So the point is, pain really is multifactorial, and not just like, oh, it's caused by like a little bit of this and a little bit of this. There's 50, 100 different things all overlapping at the same time. So again, this is where he's not wrong that nerve compression can definitely cause pain, but it's rare that your pain is 100% caused by true nerve compression.
There are many things that you can do, including creating stability of your feet, your toes, believe it or not, the position of your pelvis, your neck, your chin, all these things.
I don't understand how you can look at this, look at all of these factors that create pain, and then bring it back to, oh, it's just your feet. It's something to do with your feet. Well, let's take the most glaring example of something wrong with your feet and look at a leg length inequality. What if one of your legs is legitimately shorter than the other one? Well, this review paper showed that, well, most people actually have one leg that is shorter than the other, and it is usually small and usually not clinically significant. Usually it doesn't matter. And here's another study showing the same thing. Again, leg length inequalities don't really matter. They don't necessarily cause low back pain. Whatever he's saying about the feet is opinion-based, not research-based.
In between those, we have the discs, the soft tissue, that also have a hole through them. The spinal cord travels through that so that...
Okay, I cannot cut him a break on this. It's okay, like I get it. When you're doing a long presentation, sometimes you misspeak, but he has now, I think we're on number 6, saying that there's a hole that goes through the disc. I think we're on the 6th time on totally separate occasions. At this point, I think he doesn't know basic anatomy. And I used to like Andrew Huberman when I heard him talk about topics that I was not an expert in. It seemed really intelligent, well thought out, and well researched. But now hearing him talk about a subject that I am an expert in, low back pain and sciatica is all I do, it's obvious to me how much he just makes shit up.
Okay, it's my spinal cord that I'm bending in my lower back region. I'm allowing the discs to kind of move forward, and they likely are kind of bulging out a little bit. They're not necessarily herniating, let's hope not, but they're bulging a little bit in that direction, then back in the other direction. And if you happen to have herniated, that is bulging discs.
Well, this is terrible advice. I already hated that he started with 20 minutes of anatomy, but now that he's reiterating and telling you you should be thinking about your anatomy constantly while you're moving, that is terrible advice. So this paper was really interesting, and they looked at the language that clinicians are using to describe a person's findings on their MRI or X-ray report. And when we use language, let's talk about disc herniations or disc degeneration. If I have a patient and we do an MRI and we look at the results and I tell them, yeah, it looks like you have degenerative disc disease. That is going to freak them out. The more that patients think about anatomy, the worse their outcomes. I'm going to repeat that because this is really important. The more you know about anatomy, the worse your outcomes are, because now you're thinking about it, and in your head you're seeing one of these stupid models that has a herniation that comes out the back and it presses on a nerve and you're freaked out about it. But even these models, I'll just show you right now, this model is with basically like a balloon. They basically put a balloon in here as a disc, and then it's this really dramatic thing where you pop the balloon out the back and it looks really scary. First of all, this would be an insanely huge disc herniation, okay? Very uncommon. Second of all, it gives you the idea that bending forward actually creates a herniation that goes out the back, which I'll show you research is not true. Third, it gives you the false impression that discs are soft and squishy like a water balloon, but they are not. Discs are like a tough tire filled with chewing gum. Yeah, the material can migrate and swell, but it's tough. It's like rubber, okay? So they do not herniate like this. The more that you think about it, the worse your outcomes are. And again, this paper is a good example of that, where if I say degenerative disc disease, you get freaked out. But if I call it what it is, which is normal age-related changes, that's not so scary and you don't need to think about it. Or if I call it a disc herniation, that's a little bit scary. But if I just say there's a little bit of normal swelling on the disc, that's not nearly as scary. And then here's another study. The reason this is so important is because fear of pain is more disabling than pain itself. And if you're afraid of bending because you are picturing the anatomy and thinking that bending forward is causing a disc to herniate and swell and compress a nerve root, then you're going to avoid movement. And if you avoid movement, your body gets weak. It atrophies is the word I should use. Your body does get weaker if you don't use it. Of course it does. So if you are afraid of moving, you don't move, you get weaker, you have more pain. So we need to stop thinking about it, stop being afraid of it, start moving, start getting strong, and then you're going to get better.
There's some simple movements that one can do if done in the proper direction and in the proper way that can allow you to push that bulged, that herniated disc back under, or I should say closer to the spinal cord, okay, moving it from the kind of bulging out from between the vertebrae to closer again toward the center point of the spine. By doing that, one can take pressure off of the nerve root.
So what he's talking about are these McKenzie exercises. This is like very, very cookie cutter, basic PT 101 for disc herniations that everybody gets, McKenzie exercises. This is not some miracle. This is like the most basic cookie cutter exercise you could possibly give. And more importantly, no, it does not take your disc and put it back into place. That is absolute nonsense. And then big surprise when we actually take a systematic review of the McKenzie method for back pain and compare it against normal, even just passive therapies and advice to remain active. So not even doing a really great intervention, not even doing good rehab. The McKenzie method does not perform better than basic advice to remain active in addition to a little hands-on care. So McKenzie exercises are fine. In fact, I give them to patients sometimes, but it's not the end-all be-all, and it does not substitute a good graded strength program to get your full body strong, and it does not replace stress management, good sleep, and good nutrition, because you need to repair and heal and strengthen your body, and you can't do that without the exercise to stimulate the strength adaptations or without the recovery, which is stress management, good sleep, and good nutrition.
You can create a nice firm core that will allow you to protect all of that with plenty of space so the nerve roots are not impinged. And then, of course, by focusing on some of the stabilizers.
Core stability, first of all, doesn't really matter. I'll show you the research in just a second. Second of all, even if it does matter and helps with some patients, which it does sometimes, it does not somehow magically unimpinge the nerve. The nerves they're either going to be impinged or they're not. And core stability has nothing to do with it. I suppose he's probably suggesting that bending forward, I'm guessing, he's probably thinking that bending forward is going to herniate the disc worse and then create more impingement on the nerve. Therefore, if we brace the core, we're going to prevent the excessive herniation and nerve compression. But that is debunked. That's not true. And I'll show you research on that too. So first of all, here is a paper looking at a causal fallacy, that back pain is not caused by a weak core, and you do not need to strengthen your core in order to fix low back pain. And that is because there is not really a strong correlation between core strength and back pain. So core stability, although it can be helpful for some people sometimes when they're in severe pain, is not going to necessarily do anything for you long term. In fact, here was an interesting study that basically found that when we induce pain in somebody, your muscles reflexively contract. So actually what's happening is when you're in pain, you actually have a stiffer core than a person without pain because your muscles are overprotective. They're being excessively protective. They're trying to guard you because everything hurts. So many times, instead of trying to get you to brace more, which just creates more tension and fatigue and deoxygenation and pain, instead, we might want to explore teaching you relaxation techniques for the lumbar spine musculature. So instead of bracing your core, it might be advantageous to relax your core more and try to restore normal bending and twisting, which I know is scary to hear, but that is the truth.
Further from all of that, such as the feet, literally how you position your feet, the ability to spread your toes, believe it or not, as a way to provide support for your back, not just when doing exercise, but also at rest. There are some things you can do about neck positioning.
Okay, I wasn't even going to bother trying to research this because it's such a ridiculous claim that you've got to spread your toes and that's going to magically fix back pain. Again, go back to the part where we talked about the biopsychosocial model and how multifactorial low back pain is. But I did go ahead and try, okay? I couldn't find a single study looking at toe spreading and how that has anything to do with back pain for or against. But I did find one study that had that was looking at toe spreading in people with chronic pelvic pain syndrome. This is not back pain and sciatica, so this study does not apply to back pain and sciatica, but is the only thing I could find. What they found was that people with chronic pelvic pain syndrome were less capable of spreading their toes. Now, here's the problem, is that Huberman was basically suggesting that spreading your toes somehow is going to activate muscles and make your back not hurt as much. He's got it in the reverse order. So even if spreading the toes had anything to do with back pain, it would be more likely that the lack of ability to spread the toes would be because there's a true blue lumbar radiculopathy, meaning true compression of a nerve, leading to what we would call foot drop. If you have foot drop, that's another story altogether. But magically spreading your toes while you're doing a deadlift is not going to fix your back pain. It's just silly.
You can create a nice firm core that will allow you to protect all of that with plenty of space so the nerve roots are not impinged.
Again, bad advice. Stop protecting. Stop protecting so much. Get out of fear. We already showed you the research that shows that fear of pain is more disabling than pain itself. So get out of the mindset that you need to protect at all costs.
And then, of course, by focusing on some of the stabilizers that exist really distal with that, such as the feet, literally how you position your feet, the ability to spread your toes, strengthening of the front of the neck.
For the record, I tried to find any study ever that has evaluated neck exercises for low back pain. I couldn't find anything. There's tons of research on neck strengthening exercises for neck pain, but nothing for low back pain.
First of all, if you have back pain, you need a proper assessment and diagnosis.
So this is interesting. Having a good diagnosis actually sometimes makes things worse. This study here found that people who had an early and unnecessary MRI of the spine, which gives you a diagnosis, they're going to tell you exactly what's going on. Oh, there is a disc bulge at L4-5 with minor nerve root compression or, whatever, foraminal stenosis or something like that. So you've got a really crystal clear diagnosis. But guess what? That makes your outcomes worse. So people who had an early and unnecessary MRI were about 12 times more likely to be pushed into a surgery that they did not need. So a good diagnosis is not a good thing. Unless, of course, you have cauda equina symptoms like foot drop, saddle anesthesia, or incontinence. If you have major red flag symptoms, then obviously you need a diagnosis right away. Sometimes having a really good diagnosis matters a lot. I mean, it's the difference between paralysis and not, or even life and death. So in those cases, fine. But for 95% of back pain and sciatica, a quote-unquote good diagnosis does more harm than good.
Dr. Stu McGill has also pointed out that there are a number of things that any and all of us can do by just self-assessing that I think are appropriate for today's discussion.
Okay, I believe he's about to get into a lot of the protocols that Dr. McGill has given him and other patients, as well as probably McKenzie exercises, etc. He's going to start talking about protocols. I'm going to save that for a part 2 because this is, I mean, it's a 2-hour podcast. I'm trying to make it as concise as possible for you. But let's just break this down into a couple of segments. So the next video is going to be all about his protocols. And I think you can see where this is going. So far, he's done a decent job of at least mentioning that pain is multifactorial, but then he harps over and over and over on the anatomy. He's giving a lot of scary verbiage around the descriptions of the anatomy that we know are going to leave you more afraid of pain and that lead to worse outcomes. He's proven over 6 different times that he doesn't understand that there are no holes in the spinal discs. And again, I know he corrected himself later on some like Instagram post or something, but dude, 6 times in the same podcast that you thought that the spinal cord goes through the disc? Get your shit together. Not to mention that he's almost half an hour into the podcast and he has not cited a single flipping source. He has not cited a single piece of peer-reviewed research, and he's a frickin' PhD. Dude, come on. Hold yourself to a higher standard than that. So in the comments, I want you to tell me, have you learned something new so far? Next time, we are going to, dissect whatever he has to say about protocols. And like I said, there's probably some stuff that's decent and some stuff that's absolute trash, not research-based. So we're going to pick it apart. Stick around for part 2. I'll try to get that out as quickly as possible. But again, put it in the comments. Did you learn something new today by actually dissecting this stuff? Okay? Like and subscribe. I'll see you in the next video.